Hello, my name is Ara Keshishian, and I would like to review vitamin D, its function, deficiencies, and how to correct their deficiencies after weight loss surgery. Let's review the function of vitamin D. Vitamin D is important for bone health along with calcium. It also works with immune system in functioning, proper functioning of the immune system and its regulation. It's important in muscle contraction. It also plays a role with protecting against diseases such as Alzheimer's. It's also been shown in children to be important in development of the brain. Uh, we also know that vitamin D plays a role in anti-inflammatory, in protecting against colon cancer, for example. With diabetes, it plays a regulatory role. It also protects the cardiovascular health, formation of plaque. And there's a lot of new research going on that shows in child development and autoimmune diseases, vitamin D plays a pivotal role. This slide shows a complex pathway of vitamin D absorption. Essentially, there's two mechanisms by which vitamin D can be absorbed. One of them is sort of passively through the uh, exposure of the skin to direct light, where a pre-D3, which is a cholesterol molecule, converts to D3. This is taken through the bloodstream to the liver and through a number of different stages and mechanisms. We'll review this a little later. It essentially ends up affecting the end organ, and whether the end organ is in the intestine, that plays a role in calcium and absorption. In bone, it helps with the mineralization and deposition of the calcium. Immune system, microenvironment such as regulation of the immune system and so forth that we talked about. A second pathway for absorption of the vitamin D is clearly by oral intake. That food that's rich in vitamin D can get absorbed through the small intestine and then taken through the bloodstream into the liver and follows the same pathway. Let's look at this just for a simplified way again. Vitamin D in a precursor cholesterol molecule is converted in the skin from a pre-D3 to D3, or a vitamin D is absorbed by mouth from diet, then is taken to the liver, where at a certain position of the cholesterol molecule of the vitamin D, oxygen and hydrogen is bound to it. This is taken to the kidney, where a second hydrogen and oxygen is added to it, and now we have a 125 hydroxy vitamin D, and this essentially through the bloodstream goes to the end organs and does its function. Looking at this in a outlined way, I would like to point out a couple of things. Is that though the precursor to the vitamin D conversion in the skin is a cholesterol molecule. And this may be one of the reasons why we're seeing such a high incidence of vitamin D deficiency, because of use of statin medication. And we'll go over that a little later. Vitamin D in the D3 in the liver, it's converted to 25 hydroxy, and this is sort of the major circulating form of vitamin D. Vitamin D25 hydroxy that's now circulating in the bloodstream is picked up by the kidneys, and there are two modalities, two forms of the dihydroxy form. Dihydroxy means two hydrogen and oxygen form of the D3. One of them is at position 125, and the second form is 2425. Think of this as two similarly structured Lego pieces that have one end of it a little different, and there may be actually mirror images of it. So their function may be different, and what we know about it is that the 125 is the more prevalent and common form of the dihydroxy, the D3 vitamin. The vitamin D25 bound to a bounding protein, and the vitamin D binding protein, the DBP, then carries it over to the end organ, and it functions in that place. This is a very complex drawing of vitamin D endocrine pathway. It essentially from the left and right upper side of the drawing, it starts as to how the supplements and or vitamin D is taken by mouth in a form of a D2 or D3. It's absorbed by the small intestine, and as it's taken into the bloodstream, it's bound to the DBP, which is the carrying protein, taken to the liver, and through a number of complex, both positive and negative feedback loops, which are essentially regulating the absorption and the different stages of the vitamin D processing, essentially ends up going to the end organ, and you can see going down the path on the right side of the image as to they may end up in the cells, regulating the cell receptors, the mitochondria, which is a sort of a power plant of the cell, and or even changing the nuclear makeup, the DNA nucleus makeup of a particular cell. On the left side of the screen, we can see how the sun exposure causes the change of the skin from a pre D3 or a cholesterol molecule into a D3, which is then absorbed and essentially goes down the pathway. Throughout this, the regulation takes place, and it affects the different cells in different stages. If you look at the summary of that complex drawing, essentially vitamin D can get absorbed, and its absorption depends on a number of things, and vitamin D also regulates a number of minerals and other agents that have a positive or negative regulatory effect on it. Calcium, cholesterol, magnesium, phosphorus, protein, and water are example of it. And on this drawing on the side, we can see that, for example, with the skin, if we are exposing ourselves to less sun, if we're exposing ourselves to excess amount of UVA versus UVB, if we're lowering our cholesterol and the precursor of a D3 is diminished, as we go from the left to the right of this drawing, we can see that there's less and less vitamin D available. A second reason may be our GI tract. We're taking lower vitamin D in our food. As our magnesium is low, there's less of the calcium absorbed. There's high level of polyunsaturated fat, which is not good for us. As our body fat goes down, as earlier said, because of the statin, we have lower cholesterol, which is the precursor. Toxicity of the liver with things like alcohol can again prevent the vitamin D conversion. Smoking affects vitamin D and is consuming by in replacing the calcium. Kidney disease, pancreatic cells, and eventually this drawing shows how by number of different small variables we may end up with in a state where all vitamin D has gone down over time. Vitamin D25 or cholecalciferol is synthesized in the liver, and it's a half-life of about 10 days to 2 weeks. 125 is the active form, and it's in the kidneys, and it has a half-life of about 4 to 6 weeks. There are a number of receptors found in cell membranes locally that produce calciferol in heart muscle, and these are all the regulatory enzymes that in a feedback system regulate vitamin D and calcium metabolism. To sort of put the cause of deficiency, as we saw in that drawing, on a form of a list, kidney disease, lung disease, autoimmune diseases can all affect vitamin D or result in vitamin D deficiency. Obesity is also a major cause of vitamin D deficiency. Number of medications, advanced age, decreased activity level, or skin color, lack of exposure, weight loss surgery, iron deficiency anemia, excessive breast milk fed infants, and high intake of sodas can lower all vitamin D. And the statistics on this is overwhelming that 3 servings per week can reduce vitamin D by 12 to 13%. And if a patient is drinking, or an individual is drinking 3 servings per week, there's 50% vitamin D deficiency for significant low levels of vitamin D of less than 20 nanogram per milliliters. And we'll talk about what that means. Over the years, the scale of vitamin D deficiency has changed significantly. Numbers that 5 to 10 years ago would have been considered normal to high normal are now considered insufficient. Deficiency or very low level would be when the 25 hydroxy vitamin D is less than 20. Insufficiency between 20 or 30. 30 to 100 is considered sufficient with most of the lab results. And in my opinion, every weight loss surgical patient, if not everyone, should have vitamin D25 level of 60 to 100. These levels should be maintained so high because of the fact that it plays such a pivotal role with different functions in the body, as we discussed earlier. And I want to remind everyone again that numbers that were measured 5 years ago are and they were normal then, are considered grossly abnormal now. It is important to not check vitamin D level in the vacuum by itself. Calcium is not a good indicator for vitamin D level. Calcium will stay high in the presence of a low vitamin D until it's too late. So a normal calcium level measured in a patient without knowing what their vitamin D level is does not automatically imply that their vitamin D level is normal. In fact, to the contrary, in weight loss surgical patient population, for first few years after weight loss surgery, most patients are known to have relatively normal calcium while their vitamin D is going down. Parathyroid hormone, high parathyroid hormone with low calcium is the picture that's usually seen. We also need to check patients' magnesium and potassium level, zinc, which is important in the absorption of the vitamin D, phosphorus, which will inversely be indicator of low vitamin D level, and correction of iron deficiency decreases vitamin D absorption. So it is not uncommon in weight loss surgical patients where we encounter male patients who have low vitamin D and iron deficiency anemia, and we need to appreciate that inherently correction of one of them can limit the absorption of the other one. Supplements, usually preoperatively, vitamin D that's oil-based is adequate, and patients can also try the dry water-soluble form. Postoperatively, after duodenal switch, which limits fat absorption, the options may be D, D2, D3 in different format, and this is something that, depending on who the treating physician is and who the endocrinologist or the bariatric surgeon is, you may get different opinions on this. So this is what I like to entertain with my patients. Dry vitamin in a form of D3 50,000, and the frequency of it will depend as to what number we're starting with. It is important not to do this with fatty meals, and I'll talk that a little later. Vitamin D should not be taken with anything, and it should be taken on essentially empty stomach 30 minutes prior or 30 minutes after the food. Sun exposure, which we've all shied away, should be brought back in a sensible form. Injectable vitamin D in some patients is required, and in fact we've done this for years now, where on regular intervals patients are given large of vitamin D. The data for this comes from mostly Australia, and there's some scattered data from US that's available. Calcium citrate, magnesium, and even some information on probiotics is now becoming available. Let's briefly talk about sun exposure. We've been made scared of getting skin cancer from any minimal sun exposure, and it's very critical that we come and realize that some limited sensible sun exposure is not only acceptable but actually critical. There are a number of apps out there now that in one form or another will give you some measure of how much sun exposure is adequate and how much vitamin D you can get exposed safely. I'm sure everyone can figure out how to do a search on some Android or App Store type of thing. As far as dietary sources of vitamin D is concerned, there are a number of tables out there, and this is just one example of how many international unit per serving of vitamin D is available in food. And what I'd like to remind everyone is that all of these numbers are assuming 100% absorption in an entire GI tract. We have no idea what the implication of this is on after weight loss surgery. So a patient who's had duodenal switch operation and consumes 1 tablespoon of cod liver oil will not certainly absorb 1360 international unit per serving. What that number would be anyone's guess. I think the best measure would be to pay attention into taking diets that's high on vitamin D, and at the same time follow the laboratory studies to monitor what the vitamin D levels are and make that the measure of whether we are or we're not taking in or absorbing or exposing ourselves to enough sun to have the end result, which is a vitamin D level of 60 to 100 at least. One of the other things I would like to talk about is a number of misinformation out there that propagates in different form. One of the more interesting one is that though, if I'm low on vitamin D, which is a fat-soluble vitamin, I can increase my vitamin D level by increasing my fat intake while I'm taking my vitamin D. This is not correct. Increasing fat intake will only result in reduced fat-soluble vitamin. The rationale for my statement is that it is known that increasing fat intake after duodenal switch operation only results in much looser bowel movement and much frequent bowel movements. Increasing the frequency and high liquid content of the bowel movement after weight loss surgery only means that there is less time for the nutrients to be absorbed. So if I'm taking large volumes of fat and I'm having multiple loose bowel movements, that means that the vitamin D that I've taken in has much less time to get absorbed. So I want to say this one more time. Increasing my fat intake will not help with my fat-soluble vitamin deficiencies. In fact, if I'm taking too much fat, the chances are that I'm contributing to my vitamin D and other fat-soluble deficiencies. The second thing that I would like to mention is that it is important to read the label and the supplement instructions clearly. It is not uncommon when I would get a call from a Costco, someone inquiring about whether our prescription that we've sent or the note that we've sent with the patient has one too many zeros. 50,000 unit international unit of vitamin D, that's over the counter or it needs to be bought from compounding pharmacy, is water soluble, whereas the 5,000 international unit vitamin D that's sometimes sold in Costco's and other stores is prescription. I do not want a patient to take 5,000 units of fat-soluble vitamin D from Costco and take 10 of them to equal 50,000 units that I think a patient should take. And I would also like to question the wisdom of statements like fat is my friend. I would say fat is not an enemy, but I think it's far from being a friend, and we need to be careful as to how much fat we consume, getting ourselves into trouble with regards to low vitamin D, excessive diarrhea and nutritional deficiency, which may compound not only our nutritional state, but developing vitamin D deficiency, kidney stones, and so forth. In conclusion, what I'd like to remind everyone that it is important that we take our supplements as recommended, that overall nutritional state rather than just one or two supplement plays a pivotal role in not only our overall health but also individual nutritional state. Calcium, vitamin D, magnesium, protein, they're all interrelated to each other, and we cannot just supplement one and expect that everything else to be normal. And in fact, if one of them is deficient, we may be at a risk of developing deficiency with the others. Fat, whether it's our friend or not, we need to make sure fat consumption is not excessive and it's in moderation. And we should all remember that it's easier to stay ahead of deficiencies than try to catch up. Thank you.